the process. I still am seeing patients at the medical center in the neurology section a few days a week, so that I've still got my hand in the pie a little bit, but and still am seeing a few Parkinson's patients there as well. But in the past, I've given this talk and we've kind of made it very informal because the question and answers are different for everybody. But what I'm going to do is, everybody see the slides? Are they working okay?
Yep, all clear. You might want to, if you press the present button, you can do, let's see if I can, you can press this button right there, and that should get you started.
Right here?
Yeah, or yes, that will work too.
Okay.
And that'll make your
There we
text
go.
bigger.
Okay.
Yeah,
All
there,
right.
that
Okay.
looks great.
Thank you so much.
Mm-hmm.
Well, as we talk about Parkinson's disease, as you well know, those of you who have dealt with this, there are many different clinical features, some of which are present, some of which are not present, but certainly the pattern of arrest tremor, bradykinesia, which is the movement, slower movement of activities brought on by the rigidity. And then the rigidity, of course, produces other features such as micrographia and masked faces and stiffness. Let me do this back here. Whoops, sorry about that. The side effects slide needs to go a different place, so I'll put them back in there from now. The thing about Parkinson's disease, when we look at the diagnosis, the most important features that I look at is that it is a very heterogeneous disease. Not everybody has a tremor, probably 30% do not. The tremor dominant features may sometimes be slower and have a better prognosis. Other features that are different in that in some patients who have early dementia, that usually is a sign of a more significant poor prognosis. But the other thing that in the first line is that it's important not to personalize somebody else's story. I've had the experience of patients coming in and their friend tells their neighbor, oh, the doctor just diagnosed Parkinson's disease. And of course, you know how people are, the well-meaning person has to tell the worst story to make it relevant, you know, and so they'll say, oh yeah, my aunt had that and she died, you know, that's the only thing you hear about. And so it's important not to personalize the story. This is a very slow process in most patients, and 20 to 25 years of slow progression, and probably 10 plus or more years in which you can be very functional, and even longer perhaps.
Dr. Hill, just a quick note, if you wouldn't mind speaking just a little bit louder.
Oh, sure.
Also, if anyone out there is having difficulty hearing, you can turn the volume up on your computer and that might help as well.
Okay. The treatments are, number one, exercise, and we'll talk about that a little bit later as we go through the questions, but also dopamine replacement. As most of you know, Parkinson's disease is a disease in which the chemical neurotransmitter dopamine is deficient, and replacement of that is very beneficial. The primary drug we use is carbidopa-levodopa, but there are other drugs that stimulate the dopamine receptor directly, such as dopamine agonists, and then other adjunctive drugs which enhance the, they block the metabolism of dopamine, so the breakdown is not as much. And these are used as adjunctive drugs as well. Another component we sometimes see with Parkinson's is sleep disorders. One of the common disorders is what's called rapid eye movement sleep disorder. And patients have dramatic dreams with kicking and screaming, and sometimes injuring the bed partner with their dramatic behavior. They're acting out night pairs, and this sometimes can actually predate the diagnosis of Parkinson's disease. The treatment, as I talked about, oops, going back the other way. The DAT scan, just to mention this, is a dopamine scan now. It's available, and it does confirm a diagnosis of a Parkinson's syndrome. For instance, if I have a patient who has what looks like Parkinson's disease, but they're on a number of psychiatric meds, and we can't tell for sure, a DAT scan can confirm that they do not have a deficiency of dopamine, and that is helpful. But the difficulty is this doesn't tell us if it's a Parkinson's disease, which is more slowly progressive, versus a Parkinson's syndrome, which is more complicated and has a worse prognosis. The red flags for the syndrome, and we've talked about that a little bit, but those are diseases in which there's a very rapid onset with bilateral involvement and orthostatic hypotension, and significant bladder problems very early. These are not at all Parkinson's disease, and they're but sometimes early on, it's a little difficult to tell. The side effects of the medications are some of the ones that we deal with, can include nausea and dizziness, and sometimes severe dizziness with drop in blood pressure if the patient has autonomic difficulties, as well as impulsive control disorders, especially in younger patients with taking dopamine agonists. This is compulsive gambling and other issues with impulse control. Dyskinesias and on-off symptoms are definitely a difficult problem in patients who've had the disease for a number of years. And fortunately, we've been able to address a lot of this with some of the alterations of the way we handle the early treatment of patients. Hallucinations and freezing are some complications we see later stages. The other hope for the future, there's a tremendous amount of research ongoing, including methods to try to get rid of the the protein alpha-synuclein, which causes the cellular death, trying to figure out how the disease spreads from cell to cell, and why these cells can't handle those proteins, and they have a development of too much of that breaks down. Other non-dopamine issues that can be a problem, one of which is constipation. This frequently will predate the diagnosis as well. Urinary frequency, blood pressure issues, and then issues with dementia, some of which relates to personality change or apathy. Hallucinations and delusions are occasionally seen, but they're not as common as the affect changes. Medications that are new, or were new, I guess I'd say, when I was finishing my practice. Nuplacid, which is used for the delusional and hallucinations, especially in Lewy body disease. Rytary, which is a long-acting carbidopa that's been around for about 5 years now. It's a lot more expensive, but it's very helpful in patients who have long-standing complications. Some newer drugs, which I've not had any experience with long-acting amantadine. These have been helpful in patients with dyskinesias The Northera, which is helpful for the low blood pressure. The monoamine oxidase inhibitors, which block the metabolism of dopamine. These are helpful in improving on and off symptoms and decreasing some of the dyskinesias. The apomorphine, which is helpful for patients who have severe offs. That's a complicated, they have, for a patient to start on this, they have to go through a phase-in period of time in the doctor's office to try to get the right dosage. But once that's established, then they can give themselves a shot or the sublingual treatment. The main side effect is worsening blood pressure drop, and so that's why it has to be titrated. The inhaled dopamine, I have not much experience, I have no experience with, I should say, but the studies I've looked at say that it works fast to get on, but there are some issues with increasing dyskinesia or also blood pressure problems. And then duodopa, which is another use of dopa. It's a different mechanism, and they use that through a feeding tube. And that's been used in patients who aren't candidates for DBS due to other features, either because of cognitive issues or age. And it can help stabilize on-off phenomenon and other issues. I'm going to stop here and just leave it open to questions, because I think it's more effective sometimes to let y'all guide where I'm talking.
That's great, thanks. And then just a reminder for those of you who have recently joined us, if you would like to ask a question, you can press the chat button near the bottom of your screen and type that in there. Or you can, if you want to ask your question out loud, you can press the reactions button and then the raise hand button. And I can work on calling on people who might have questions. There was one question from Debbie, is how is the medicine dosage determined?
The first, how the medicine dosage is determined on the patient's clinical symptoms. For instance, if a patient has just a mild tremor and some stiffness of their non-dominant hand, we might not treat them at all. Nowadays, most of the time, unless the person is, say, less than 50, we would use dopamine to start with and use the Cinemet, and generally always started at 3 times a day, which is usually always a very standard dosage. L-Dopa is metabolized quickly in the bloodstream and is then stored in the brain, but theoretically, they need a real steady dose throughout the day to avoid complications in the future. So we establish usually 3 a day at a very low dose of 25/100, and then that's established what is the symptom we're trying to fix. In other words, if the patient has a hand that's not working and their leg is stiff, we try to assess whether or not that produces the improved movement or decreased tremor that we would expect. And at the same time, we don't anymore try to cover up every symptom. We try to, it's all about function. In other words, if the patient is functioning well, we may not need to add symptoms. We only just watch for a while. Or we might add a monoamine oxidase inhibitor, which has been shown to kind of slow down a little bit of the progression of the disease. But it's very individual.
Great, thank you. And then Judy had a question about DBS. So what symptoms can deep brain stimulation help?
The deep brain stimulation, you think of that, it's electronic dopamine. So anything that is responsive to dopamine will respond to DBS. Anything that you expect doesn't respond to dopamine is not going to be better with DBS. So for instance, if a patient has a lot of freezing and difficulty with movement of their legs and bad balance, DBS won't work for that. If they have prominent tremor, difficulty with stiffness of their arms and legs, those respond dramatically to DBS.
Great, thank you. And then as other questions keep coming in, I'll just ask some questions. So what would be some things that people could look out for that might cue them into, thinking maybe it's time for a medication adjustment?
Okay. The most important thing, and this is a question I would ask patients whenever they came in, is what do you do all day and how well can you do it? So it's all about function. And if, for instance, if the first thing we sometimes run into once we start somebody on medication is a wearing off of the medication. They take it, and at first, in the first few years, they take it and they never notice any problem. And then after that, they notice that right after they take their pill, they seem to be a little bit, the second pill, they start to be a little worse. That's because the second pill hasn't started working yet, but the other one from before is starting to wear off. So changes in response to the medication would be something else to look for. The other thing is if you're having symptoms such as dizziness after you take the medication, excessive movements or so-called dyskinesia, where you have wiggling of your arm or leg or head or this kind of thing, those would be changes you would look for as well.
About Great, thank you. And I just, again, want to encourage people. Oh, we just got one in. Great. Jean asks about the Duopa device, and have you ever seen it used?
I have a number of patients that have had it used, but because it was something that came about in the last year of my practice, I referred all my patients to another provider who was taking care of those patients. It was very successful. The process is that they put in a permanent feeding tube into the duodenum. So it's not like a regular, just plain old stomach tube. It's a little more complicated. But that once you have that feeding tube in place, then you put the feeding tube and hang it up and put the medication in on a continuous basis throughout the day. And there's a pump that's involved. And it's been very successful. This is used in patients who can't stay on well. In other words, some patients who have had Parkinson's for a long time, their stomach, and when you think about the medication, it has to go through the stomach and into the small intestine to work. And sometimes the stomach's real slow, and sometimes the absorption is erratic and it gets into the small intestine and it's absorbed real quickly, and it's just not a smooth process. And that's what is the problem, and as you've had Parkinson's for a long time. And the smooth, consistent pumping of dopamine into the small intestine is very effective in dealing with the complications of wearing off and ups and downs and on and offs.
Great, thanks. And then for some of those who may be newly diagnosed, can you explain why it's so important why the timing of medication is so important and why it should be taken in the same window of time every day?
Okay, if you first have Parkinson's disease, and it's very early in the course. It's not important necessarily that you get it exactly right, but the window of time for absorption is in about an hour, and then it is metabolized in about 3 hours. And if you, then it's stored in the brain. And so when you first have it, we try to give you a steady dose so that your brain is not exposed to what we call pulsatile stimulation. We used to give patients in the 60s and 70s whatever they wanted and whatever would cover up every symptom that they had. And we realized that that was not a good situation because they had severe on-off complications, something you never see anymore, fortunately. And for a period of almost 20 years, we were afraid of dopamine and would not use it until patients were really severely handicapped. Over time, we realized that, and that was really at the same time when we had a lot of dopamine agonists available. But over time, it was, if we treated patients more carefully and didn't give them enough to cover up all their symptoms, but gave them lower doses early on, they did very well and their quality of life was much better than if we waited. And so it's very important to maintain kind of a steady state early on to avoid the complications that may come in the future. So sporadic or erratic taking of the meds could lead to more complicated on-offs in years to come.
Great. And then Debbie has a clarifying question. Did you say the medicine only lasts 3 hours, or how much time is usually taken between medication doses?
It's complicated in that in the bloodstream, it's about 3 hours, but in the brain where it works, it stays for days, especially when you first have Parkinson's, because you've got a lot of extra cells to store it. And so the problem is after 5 to 10 years, your storage mechanism is less and you start getting an off. And that's the only time it's really so complicated that the blood and the brain are almost equal. But in the days when you first have it, you could take one a day, really, and your brain would store it for you and you just keep going. But it's not a good practice just because theoretically, we've never proven that it's bad, but theoretically it's better to have a smooth sailing of a steady state. And we've tried doing it 5 times a day, but that hasn't proven to be better than 3. So it's more complicated to take 5 a day when you don't notice a difference. So that's why we do it that way now.
Thanks. And then Jerry wants you to talk about the relationship between Parkinson's and dementia and Alzheimer's.
Okay. Parkinson's has a component of dementia in later stages, and it has a first cousin in dementia with Lewy body disease. But Alzheimer's is really a different condition. Alzheimer's is a condition in which, with the dementia, has severe memory impairment and not really patterns of personality change and apathy, whereas in Parkinson's, in the later stages, there is a component of dementia that can occur, and that is usually manifest as personality change and apathy and depression, and later on can have some component of delusions and hallucinations. There are actually 2 different pathological mechanisms in Alzheimer's disease. The pathology is related to the acetylcholine neurotransmitter, whereas in Parkinson's, it's dopamine. So it's different cell types, but they're both devastating components or problems. in the diseases in which they occur.
Thank you. Victor asks, I've been advised to avoid eating foods with protein 90 minutes before and 90 minutes after taking my medication. Why is that?
The protein problem is one in which if you think about in the small intestine, you're trying to get the dopamine into the small intestine when it's there. And if you have protein there, those are made up of amino acids, and dopamine is an amino acid. And so if you have too much steak in there, it's not going to absorb as well. And so if you have problems with absorption and making sure you're going on and off like that, it's better to have an empty stomach, and the dopamine is absorbed much more smoothly and consistently.
And then building on that, are there any foods that have, maybe a surprisingly high amount of protein that we might not think of? So you might think of, steak and eggs as high protein, but are there other foods that might be kind of sneaky sources of protein that people should avoid right around when they take their medicine?
I don't think, you think of, certainly there's plant protein in vegetables and things like that as well. So I think it's probably best to avoid, a lot of vegetables and that sort of thing as well.
Thanks. Sylvia asks, my mother just started taking levodopa in November. At what point should we consider changing medicines? Or she mentions the rotary.
Oh, that's something, the Rytary is
Rytary,
one.
yes.
Yeah, that's only for patients who have very complicated on-off phenomenon way in the future. You and dopamine and the L-dopa are going to be friends for a long time. That's not something that will change. It might be in 3, 5, 7 years, you'll be taking 5 a day instead of 3 a day, or however you're taking now. But the Rytary is really saved for patients who have a lot of complications, and it's not at all necessary to change in an early stage at all.
Great. Robert asks, how can one separate whether dyskinesia is due to Parkinson's medications or extrapyramidal syndrome?
I'm not sure exactly, but extrapyramidal syndrome is really related. The idea of extrapyramidal syndrome is, I guess you're saying, related to medication side effects from psychiatric medication. Is that what you're asking?
Let's see, Robert, if you can clarify exactly what you mean by extrapyramidal syndrome in the chat, that would be helpful. Yes, correct. That's
okay.
What he...
Okay. Well, the one thing about the dyskinesias from Parkinson's disease are dose related in that they tend to be peak dosage. There's two kinds really. There's peak dosage, which is right like at 2.5 hours or 2 hours after you take your dose. And they're wiggly types, kind of movement, real rapid movements. The other ones are dystonic, which are kind of crampy type, which are right at the end of your dosage. Those are typical of Parkinson's disease. The extrapyramidal syndrome, which I'm thinking you're asking about, the so-called tardive dyskinesias, those are constant. They don't really fluctuate with dopamine. They might be a little bit worse with the dopamine, but they would be pretty constant. And they have a different manifestation that they tend to be mouth movements, which are not typical dyskinesias by themselves. and they can be head and neck and other kinds of things. But the fact that they're more constant and that they might have a more characteristic mouth movement with the tongue would make you think that they're more likely dyskinesia or extrapyramidal side effect from the medication, from psych medications.
Thank you. Diane asks, what if someone diagnosed with Parkinson's based on symptoms like tremor, gait issues, cannot tolerate even a tiny dose of dopamine agonist or dopamine? Dementia has been ruled out. Cognitive skills are outstanding. However, neuromuscular problems are major, and the person, to the point where the person is no longer ambulatory.
Okay, now you might start the first part of that. They've taken some medicine, but it doesn't help. Is that it?
It sounds like even a small dose of medication is not able to be tolerated.
Ah, okay. The most common problem dealing with that is the one slide I talked about where I talked about the syndrome. There are patients who have what we call Parkinson's plus or Parkinson's syndrome, and that's a dopamine. That's a picture that looks exactly like Parkinson's, but is not a dopamine deficiency. And the fact that the medication is not tolerated is a red flag for this being more of a syndrome. And I'd be concerned about that, but certainly talking to your doctor about that option, and so he can ask more, have a conversation about, is this a syndrome, Parkinson's syndrome, and not a Parkinson's disease, because that's a red flag. And I've had patients like that, and it was really hard for me to say, when they'd come in, they said, I can't take it. And then I'd get mad at them and I'd say, take it. And then I realized after having experience with that, and I have a few more patients, and said, it's not their fault. Why should I be mad at them because they can't take it? Because it's a side effect. That intolerance is part of the disease process because it doesn't work. And that should be talking to their doctor about the syndrome and what that means and what other kinds of, which one of the syndromes maybe would that be an option for?
And then a follow-up question is, Parkinsonism the same as the syndrome you can talk about? So maybe if you can give a distinction between Parkinsonism and Parkinson disease, and then some of the Parkinson's plus.
There are just a lot of things out there, but Parkinsonism, the way I think of it is that's just all of them, okay? And Parkinson's-ism, it has Parkinson's disease, and Parkinson's plus is the same as Parkinson's syndrome. In other words, it's Parkinson's plus some other stuff that's not in typical Parkinson's disease. So if you have Parkinson's disease and you have dopamine, lack of dopamine response, you have low blood pressure, you have early dementia with hallucinations, you have eye movement disorders, you have bilateral rigidity. So that's Parkinson's plus. It's different than the classic Parkinson's disease. But Parkinsonism just is kind of the big umbrella that they fit under.
Great. And building off of that, can you talk about the process that you go through to try to determine if someone has Parkinson's disease versus one of these Parkinson's plus syndromes?
Sure. The biggest process is the time that I spend with a patient. In other words, I have a patient who comes in and they said, well, I have a tremor in my hand. And then I asked, can you walk and can you have trouble talking, and find out all the stuff that's working and not working. And then in that particular situation, early on, the patient may have some stiffness on one hand and a little bit of tremor. And I can't tell, and most people can't tell, if they're going to have the disease or the syndrome right away. If they have early onset of what we call autonomic problems, low blood pressure when they stand up that drops real quickly, orthostatic hypotension, or if they have a lot of bladder trouble early on, with control of the bladder and infections and things like that, or if they have some abnormal eye movements. Those are the things I look for early on. The other thing I look for early on is the finding of they have it in both sides. In other words, they're stiff in both arms and they can't walk as well, but both arms are stiff in the first few months or in the first year or so. In that situation, they're all red flags, as I mentioned on my thing, for the syndrome. In somebody with unilateral involvement with a tremor, they're more likely to have Parkinson's disease. And 3 years later, I may see that, well, they're really going to have a syndrome, but we don't know what it is yet. I've had experience with some patients that were unilateral and had stiffness and tremor, and then in a couple of years they were stiff, but they never really responded very well to the dopamine, and that certainly is another red flag in that case too. But a lot of times it's just spending some time. One of my mentors was a guy from one of the neurology places in England called Queen Square, and he was a Parkinson's specialist, and he told me years ago, he said, when you see a patient and you diagnose Parkinson's disease, the two of you are going to slog through the future together. And that really came home to me as I talked about that, because I was in practice for over 40 years and saw many patients for 20 plus years, and we did slog together through thick and thin, and sometimes a lot of thick, but that's what it takes.
And then just a note to everyone, please keep your questions coming in. If I don't have any more questions from y'all, I'm going to keep asking questions. So the last couple have been from me. If in the event that someone with Parkinson's has to go to the hospital, sometimes the doctor wants to take them off of their Parkinson's meds. What would be your recommendation on how best to deal with this?
Well, it depends on the situation. For instance, if somebody has a problem with something in which they can't take something by mouth, you really can't, say a stomach problem or something like that, then they really can't get by without they can't take the medications, then that's probably okay. Patients with Parkinson's, most of them can get by with not taking the medication for a few days if they don't need, if they're sick with something else, and that's really important to get over what their problem is. Because if they can't take it by mouth, there's not a good way to get it in. You can't give dopamine IV, and you can't give the duodopa acutely like that. And in a few days, it's not a big problem. We used to do that all the time. If I had somebody with Parkinson's who, for instance, had a stroke and couldn't swallow, and we were dealing with a lot of other issues, that we would go ahead and leave off their medications for a while and then start it back kind of a little bit lower dose. Not a problem usually. If they can take things by mouth, then it's important to go ahead. Usually in the setting of acute illness, the patient can tolerate being off their meds for a few days without any major issues.
Great. Is there anything different about the course of disease who is diagnosed in their early 40s? So, so someone who might be an early onset versus someone who's diagnosed sort of in the classical window, sort of in the 60s or 70s?
Generally, I would say that a lot of the patients who have the early onset disease tend to be a little bit more benign. I had a number of patients who started in their 40s, and they were very functional with very slow progression compared to the patient who started, say, in their 70s. And I think it's the patients who are younger onset probably have one of the autosomal recessive forms of the disease, in which it's very much more slowly progressive. And they don't have as much a relationship to the dementia complication as well. And though it's, you can't really say 100% about that, but that's as a general rule.
Great. I'm wondering if you can talk a little bit about some of the other, what are some of the main comorbidities in Parkinson's disease, and do they tend to precede or follow Parkinson's disease?
Okay. Well, I guess you look at one of the other slides I was talking about, some of the issues that you deal with in Parkinson's disease are difficulties with constipation, difficulties with swallowing and speech, difficulties with balance, tendency to fall, tendency to have freezing. Those are all things that come on later in the course of the disease, when their rigidity is much more complicated and much more prominent. There's not any other specific comorbidities that you would say it doesn't go along with hypertension or diabetes. I mean, certainly you can have patients that have those things, but they don't run together particularly.
Okay, and what advice do you have for someone who might not have access to a movement disorder specialist in their area?
Well, I think the options, I think it's important to have a neurologist at least once in a while. And depending on if there's no movement disorders, I think if you have a good neurologist, they can handle most early onset Parkinson's type problems. The other option in Texas is there's movement disorder specialists in all the bigger cities that are around. And so, San Antonio, but especially Houston and Dallas and Austin. So if you saw a movement disorder specialist once in a while, once every year, for instance, even, or saw one who made some recommendations to your local doctor, those are all options that you might look at in that setting. But most neurologists are trained in treatment of patients with Parkinson's disease, and they certainly have experience in that. They have a few patients in their practice, at least most of us did over time, for sure. And once you have a few, they just hang around. They're going to be there for a long time. So you kind of get experiences together, you and the patient.
Right. And then just in your experience in the last year, how has the field of neurology and or movement disorders within neurology, how have they dealt with transitions to telehealth?
Well, the main thing, like the clinic I work in now, we did telehealth for a few months, and then we still do some telehealth now where we communicate with the patient by phone. It's very difficult to, you can't examine a part. We're not doing it by Zoom, but just by telephone, which isn't very good. I think if you had a Zoom call, you could certainly almost evaluate the patient, just because you can watch them walk up and down the hall, or you can watch them, see how they're responding and that sort of thing. But it's that's what we've been doing mainly by telephone, but other people have been doing Zoom calls, I'm sure, and that would be, I think, a better way to do it. You get face to face and you get to see what the patient really looks like.
Great. Do you have recommendations for other medical specialties that, someone with Parkinson's disease might benefit from going to?
Depending on the patient's issues, I'd certainly have patients who sometimes need a gastroenterologist because of chronic constipation or difficulties with slow movement through the stomach and this sort of thing of the medications. Certainly, urologists are somebody we need a lot of help with because patients with Parkinson's can have urinary urgency and frequency and nocturia, so that they have to go to the bathroom a lot at night and stuff. And the urologist is very helpful in dealing with those issues as well. Certainly, we use a lot of professionals with physical therapy and occupational therapy and speech therapy. The other thing I used a lot with my patients was using personal trainers. Sometimes, I talk to men about exercise, but it's absolutely the most important thing that can be in somebody with early Parkinson's disease. You're getting stiffness and tightness in your muscles, but there's nothing wrong with the nerves and with the brain. It's the muscles that are tight because of the balance of the dopamine. And so you need to have stronger muscles to make a move and have better energy and better flexibility. So using yoga and resistance exercises, that helps as well the cognitive issues. And so I had a number of my patients who wouldn't exercise on their own, and I finally just said, okay, you've got to have a personal trainer at least twice a week to work out. And the guy who never did anything at least did that twice a week, and everybody felt better, I think, for having done that.
Is it ever too late to start an exercise regimen?
No, I don't think so. I mean, I didn't start my personal trainer until I was 72, and I'm 74, but I feel better for having done that just because I'm more flexible and I can actually turn and look behind me when I couldn't do that before. So it helps no matter when you start.
There's a question. Are you aware of any specific movement disorder specialists in the El Paso area?
No, I don't know of any specifically, but what I always tell patients now, because most of the guys that I knew are retiring, but if they know their family doctor, they're in town, the family doctor will know who the who the other neurologists are who do that kind of thing. And I would recommend they talk to that. There's also, there may be through, I'm not sure where to look it up, but you can just Google movement disorder neurologists, and there's organizations that keep track of that and where they are. So you can look that up that way. But you don't know if that's a good one or not unless you talk to the doctor in the area anyway. So that'd be good to know. So.
Right. And then Sylvia, that's the one who asked that question. Sylvia, if you want to reach out to CAPS, we can help, get you put in touch with some people who may know some specialists in that area. Can you explain anything you've heard about Parkinson's, meds, and the COVID vaccine?
I haven't heard anything about the relationship. I would not think that there's any complication with those issues at all. I don't think there's a relationship at all.
Okay. In other places of the country, is it possible to be seen by neurologists or movement disorder specialists who work as a team with other specialists that you're mentioning? And, why might that not be in Austin?
I am not aware that except that anybody's doing that specific program, though some of the big medical centers may have a program like that. That's usually used more in the setting of patients who have ALS, for instance, amyotrophic lateral sclerosis, where there's a lot of needs as the patient deteriorates very quickly. And in that situation, what happens is you go in and you spend the whole day in the clinic, and you see the physical therapist and the occupational therapist and the neurologist and the gastroenterologist and the all, you say 10 different specialists all in one day or in 2 days kind of thing. And I don't think that in Parkinson's that's been a program that I've seen anywhere. But some places may have it, but I think the progression of Parkinson's is slow enough that it really doesn't fit into the need for that kind of a multidisciplinary approach all in one place. I think it's, but there may be some that are doing that. I'm not aware of that.
Okay, and then we're almost at time. Thank you so much. But I just have one last question. Do you have any tips for spouses, family, or care partners of people with Parkinson's disease?
Whoa, that's the hard part, isn't it?
It's a big one, yeah.
No, I think 2 things. One is look for the fun every day to make life better, because there's bad stuff every day that you got to deal with, but look for the fun of every day, not just for you, but for the patient as well. What can you do that you can enjoy? What can you do that is happy today? Because this is an attitude, I think, that you deal with, where you're, as one of my patients told me one time, he said, I asked him what he's doing after he retired. He said, I just do Parkinson's, but I think my experiences with dealing with that, just as a caregiver, try to find, besides the joy, look at the things that help function. So if you're having problems with function, do you need some physical therapy? Do you need a ramp? Do you need a walker that works better? And those kinds of things. So look at how your house is, look at the things you can help to make life better every day for both of you. What's hard on you, try to find a way to do it easier, and take care of yourself as well.
Thank you. One last question from Diane, just should be a quick one. Are there psychiatrists who are especially knowledgeable about treating people with Parkinson's disease?
Not that I'm aware of. There really aren't any in Austin. I don't know of anybody who's a specialist in treating the Parkinson's patients. I did have a few of my colleagues who were helpful in patients who had cognitive difficulties, but they were mainly their specialty was the dementia component. So that's different altogether. So I really don't know about that. But
certainly psychiatrists may be able to help with some people with Parkinson's, correct?
Oh, absolutely. I mean, I think there's several issues with Parkinson's, especially psychiatrists and psychologists both, where you're dealing with things such as cognitive behavioral disorder, trying to just deal with, okay, I'm dealing with this. How can you help me cope with that? And I think psychologists as well as psychiatrists can be very helpful. And I just don't know of anybody who's just, who just works with Parkinson's patients.
And then Robert Camper had suggested Dr. Lusk has several patients with Parkinson's disease, but is not taking new patients at this time. So just for those who are interested. Yeah. So we'll wrap up. Thank you so much, Dr. Hill, for lending your time and your experience and your knowledge. to answering these questions. And for those of you out there who may have a question that pops up once we close the Zoom, or who are watching and weren't able to attend live, please reach out to our CAPS email. So that's info@capitalareaparkinsons.org. And we can help get you the answers that you need and help connect you with some of the local services that can help you. All right, and we are looking forward to seeing y'all in March. We're going to keep with our normal March date for our meeting, and so we will be seeing you just in a few weeks. I hope everyone was able to stay safe and warm and fed through our winter storm last week. And thank you for your flexibility, both Dr. Hill and then everyone who was able to join in rescheduling this. All right, take care, and we will see you in March.
All right, thank y'all. Thanks for coming, everybody.